Areas of focus for the radical retropubic prostatectomy. Description of the surgery. Reasons for the surgery. Approaches to take. Anesthetic use. Postoperative diagnostics. Nursing assessments. And discharge planning.
A radical retropubic prostatectomy is a surgical procedure performed to treat prostate cancer. The procedure involves the removal of the entire prostate gland, the seminal vesicles, as well as part of the bladder neck called the ampulla. In some cases, the lymph nodes and surrounding tissues may be removed and examined to determine if the cancer has spread beyond the prostate. The surgery is typically performed by a urologist, and the patient usually spends 2 to 3 days in the hospital, followed by a discharge home with a catheter for 2 to 3 weeks.
The reason this surgery is performed is to treat individuals who have early-stage prostate cancer confined to the prostate gland, or if prostate cancer has failed to respond to radiation therapy. The population that this surgery is generally performed on is older men who have a higher risk of developing prostate cancer, typically seen in men over the age of 65.
Surgeons utilize several approaches for radical prostatectomies, such as laparoscopic approaches with small incisions in the abdomen. A robotic-assisted approach is a type of laparoscopy utilizing a computer, camera, and microsurgical instruments. These types of surgeries are less invasive. Cryosurgery is used to destroy cancer cells by freezing the tissue with liquid nitrogen. A few common open surgical approaches utilized include the perineal resection approach, the suprapubic approach where a midline abdominal incision is made, and the retropubic approach. With the retropubic approach, a low midline abdominal incision is made to access the prostate gland. The prostate is removed from the urethra below and the bladder above, and therefore the bladder must be reconnected to the urethra. Blood vessels that were connected to the prostate gland are then tied off, and the pelvic lymph nodes can then be dissected. Urinary incontinence and erectile dysfunction can be adverse outcomes. With select eligible individuals, surgeons can also incorporate nerve-sparing procedures in which the neurovascular bundles that maintain erectile functioning are preserved while still removing all of the cancer.
Patients undergoing a radical retropubic prostatectomy receive general or regional anesthesia. Due to the length of the procedure, general anesthesia is most commonly used. However, research shows that spinal anesthesia combined with sedation decreases post-operative pain and results in a faster recovery. Ultimately, the anesthetic technique is determined based on the patient's physical and mental status, age, history, and pain tolerance.
A post-operative diagnostic test used for the surgery is the prostate-specific antigen test, also known as PSA. This is required after the surgery to see how well the treatment worked and if the cancer will come back. PSA is only released by the prostate, so after the operation, the numbers and levels of PSA should be at 0 within 4 weeks of the surgery. If the levels come back greater than 0.2, it can indicate the cancer is returned, which is why this test is done every few months after the operation to ensure the levels remain low.
The goal of nursing assessment and interventions is to prevent post-op complications. Common complications include urinary incontinence, stricture of the viscourethral anastomosis, and impotence. Aside from common nursing interventions such as mobilization and hydration, it is important to evaluate for any signs and symptoms of these complications occurring. After a prostatectomy, it's important to monitor outputs and the patient's ability to void. This may also include bladder scanning to ensure that they're not retaining any urine and or their bladder isn't distended. They also may have a continuous bladder irrigation to flush out any blood clots, and it's important to evaluate the fluids that is coming out of that and to ensure that it's still working properly. They will also have perineal exercises that they can do to promote bladder control and regain muscle control of their pelvic area. Redevelop the muscle control of their pelvic region.
Discharge teaching. Rest at home is going to be crucial for 3 to 4 weeks after hospital discharge. The hospital will discharge you with a urinary catheter that will be removed within 1 to 3 weeks. Other possible factors at discharge could be the use of a Jackson Pratt drain, where you will be taught how to empty and care for this. For home wound care, the dressing will need to be changed once a day, if not sooner if it becomes soiled. The wound will need to be kept clean with the use of mild soap and water. The wound dressings can be removed when taking a shower only if sutures or glue were used to seal your skin. You do not want to use a bathtub for cleansing while the use of a catheter is in place. Upon removal of the catheter, your physician may approve these activities. You will not be permitted to drive for at least 3 weeks post-discharge from the hospital. No heavy lifting will be permitted for the first 6 weeks. Over time, you can generally build back to your normal exercise routine, but it will be very important not to overdo it. With the urinary catheter, your bladder will experience some spasms while the catheter is in place, and your physician may prescribe medications for this. The drainage in your catheter bag may be a darker color of red, and this is normal after this procedure. You will also need to know how to clean the tubing of the catheter and the area that is attached to your body so that infections can be avoided. After removal of the catheter, there may be blood in your urine, urinary incontinence, a burning sensation, and quite often an urgency to urinate. These are all normal feelings after the catheter has been removed. The use of Kegel exercises can help you strengthen your pelvic muscles, and you can perform these anytime while lying down or sitting.
Other areas of teaching: drink lots of water, eat fruits and vegetables, use stool softeners to prevent constipation. You may encounter some sexual problems such as lack of erection, lack of orgasm, or lack of semen during orgasm. These issues may take some time to dissipate. Also, it is very important to watch for signs of infection, such as increased pain, swelling, warmth or redness, red streaks leading from the area, any pus draining from the area, and a fever. You will also want to check with the surgeon on the use of certain drugs that may cause clots in urine, such as aspirin, ibuprofen, and Aleve.